it becomes very challenging when we have a lot of low blood sugars and high blood sugars in people who have type 1 diabetes. So insulin titration becomes a very essential part to know. And also that, it is not just the insulin, there are several other factors that are involved in these spikes of blood sugars that are there. So it becomes very essential that each of the part is taken into picture before we move on to insulin titration. So I'll be addressing these questions today, and I'll be keeping it very simple. So we would like to understand the normal release of insulin in the human body in a person who doesn't have diabetes. We would like to know what is the ideal insulin, how do we start insulin doses, and what are we trying to achieve. And then we will move on to the insulin titration, the general principles. We'll study the pattern, and then we'll find out how to fix the lows and the highs. So this is how the normal blood glucose level of a person who is a non-diabetic looks like. So it's a range of 80 to 120. And this is basically being maintained by the insulin release in the body. As you can see, there's even in the fasting state, there is some amount of insulin being released 24/7. And whenever the person is eating their meals, there are large amounts of insulin spikes that can be seen that is going on in the body. And when we are starting insulin in a person who has type 1 diabetes, we try to mimic this natural insulin in the body. So we go by this basal insulin that we talked about, or the background insulin that is ongoing, and we give what is called the basal insulin. And then for the meal times or for the high blood glucoses, we replace it with the bolus insulin or the prandial insulin. So how do we consider why choose one over the other? What are the ideal insulins that we're looking for? So the ideal background insulin that we talk about should be peakless, so that there is reduced risk of low blood sugar, and it should be having a longer duration of action so that we don't need to give it multiple times in the day. So as you see here in the figure, the green line is and the red line here is the one that have a little longer duration of the action. But when we look at this, these glargine and degludec insulins, these are the ones that once they start working have a peak, do not have a peak and have a long duration of action. So they are considered the ideal insulin to be started. These are this is the intermediate type of insulin called the NPH, which was previously used as a basal insulin, and it used to be given twice a day. But as you can see, it has a good amount of peak, and then it doesn't last very long. And even detamir, it used to have a little bit of the peak, but then the duration of action would be only 15-16 hours. Moving on to the ideal bolus insulin, we would like the bolus or the mealtime insulin to work for the high blood sugar or the food, and it should be matching the glycemic peak of the food, and it shouldn't be lasting after the effect of the food is gone. That would be considered the ideal bolus insulin. So when we look at that, as you can see here, this is an ultra rapid acting insulin. The figure is not showing over here. So it acts within 5-10 minutes, and the duration of action is 3 to 4 hours. Then we have the Lispro, Aspart, and glulicin insulin analogs that would start working within 15-20 minutes and peak around 1.5 hour, 1 to 1.5 hour, and then they'll be gone out of the body by 3 to 4 hours. We also have the regular insulin that will peak around 2.5 hours, and slowly it goes out of the body over 4 to 6 hours. So why not pre-mixed insulins? So there are pre-mixed insulins that are available in the market, or the previous days we used to have the NPH and regular insulin, which is still currently being used. So what are these pre-mixed insulins? They have a varied combination of rapid acting insulin and an intermediate acting insulin. So some percentage, say for example, if it's a 70-30 premix insulin, 30% of it is acting immediately and lasting in the body for 3 to 4 hours, and 70% is having a prolonged effect which will last for 8 to 12 hours. So when we are giving these insulins twice a day, I would like you to focus on the lower figure here. You can see there is some amount of stacking of insulin that is going on around lunchtime. So there is a low blood sugar risk, and again at bedtime, or if the person is about to eat a very large meal with a large amount of carbohydrates, they're going to need an extra dose of insulin. So these insulins are not physiological, and they carry an added risk factor of low blood sugar as well as at times high blood sugar, and also need very there should be a consistency in the meal routines and the physical activity. So these are not recommended to be used anymore. Now, moving on to how do we synchronize these insulin with the meals? I'm not going to go into very much depth of the this topic because this is going to be covered later on. So what we're trying to do is we're matching the insulin dose to the food or the carbohydrates that the person is eating. And that is the best way to actually give insulin, when we're matching the insulin dose to the carbohydrates, because we don't want the quality of life to be gone. We want some flexibility to be maintained. If we imagine ourselves, we would not want to eat the same kind of food, same kind of carbohydrates all the time. So even though overall the carbohydrates are fixed on a day-to-day basis, but we should be able to give that quality of life to the person who has type 1 diabetes also. That does involve a significant amount of education that revolves around counting the carbohydrates. And as you can see, the maximum effect of blood glucose is due to the impact of the carbohydrates, and there's some impact that is seen with fat and protein as well. So the insulin doses should be matched with the carbohydrates, and that will allow a lot of flexibility to the person. Now, this will be covered in detail later on, so I'm not going to go into too much detail. This is how the carbohydrate counting is done. Either we calculate the exact amount of carbohydrates, or we give the person a carbohydrate exchange list through which they can look at it and easily calculate the carbs. Now, how do we initiate insulin in a person who is newly diagnosed with type 1 diabetes? As I said, there is no fixed dose. There are going to be sugars that vary throughout the day because of several factors, and also they may have different amount of carbohydrates at different times. So we do need to adjust the insulin accordingly. So when we are starting insulin, we look at the total daily requirement of insulin in the day. That will depend on the body mass index of the child, the stage of puberty, are they having any ketoacidosis or are they sick, and the age of the child. And 40 to 50% of this total daily dose goes into the calculation of the basal insulin or the background insulin, and the rest of the percentage goes to the bolus insulin. But because we are not fixing this bolus insulin, we are giving a varied regimen for a better control. We prefer to calculate using these formulas called the insulin sensitivity factor or the correction factor, which can be calculated by 1800 divided by total daily dose, or the insulin to carbohydrate ratio, which is calculated if you're using the rapid acting insulin with this formula of 500 divided by total daily dose. So let's look at this scenario. This is a 5-year-old girl who was initiated on subcutaneous insulin therapy, which is the basal bolus therapy using glargine and insulin aspart prior to each meal or snack. Her initial A1C was 13%, and she was followed up in 3 to 4 months. And she was checking 3 times per day. And when she came back for the follow-up, her blood sugar chart was seen, and she was having a fasting blood glucose of 82, pre-lunch of 128, and pre-dinner of 140. It looks like a big achievement to us, but then somehow I was able to convince them for them to put on a sensor, and this is what was seen. When the sensor was placed, as you can see, the red circles over here are the times when she was recording the blood glucose, and they look perfect. But in between, you can see 50% of the day was spent in high blood sugars of more than 250. And then her HbA1c returned as 9.3%. So we do understand the need for checking blood glucoses multiple times a day, or the need for placing a continuous glucose monitoring sensor. International Society of Pediatric Adolescent and Diabetes recommends to check at least 8 to 10 blood glucose checks in a day for us to get a proper estimation of whether we need insulin adjustments, how is the control. Practically, it becomes very difficult. So, if affordability is not an issue, it is recommended that continuous glucose monitoring sensors do be placed. Now, what are these? These, again, this will be covered in another talk. So, CGM device has a filament that goes under the skin. This is how it looks like. That's sensing the sensing the interstitial fluid glucose level, which is being transmitted to this receiver, and then that is sending the signal to the device or the phones where we're getting the readings continuously. There are various types of continuous glucose monitoring sensors, but basically the importance of it is to help with glycemic control. Let's look at another scenario here. 18-year-old female diagnosed with type 1 diabetes. She was started on twice a day premix insulin by a general physician, or I think a diabetologist. And the initial HbA1c was 12%. 6 months after treatment initiation, her HbA1c was perfect. It was 6.2%. And her fasting glucoses were 80s, and post-meal blood glucoses were 180s and occasional 200s. But somehow she was told, let's seek a second opinion just to see. Now, a blinded CGM was placed when she came to me, and this is what was seen. 33% of the times her blood glucoses were lying in the low range, and there were some highs too. So, of course, low blood glucoses are again a detriment to a person who has diabetes, or anybody actually. And then we would have a normal HbA1c because it is averaging out because of the low blood glucose. So, the importance of CGM or checking more frequently is very important. And again, needless to say, we do not recommend using those premix insulins. That brings us to what is our goal of glycemic control. So of course we would want an HbA1c of less than 7%, or even less than 6.5% for those who are in remission, or using continuous glucose monitoring sensors or insulin pumps. But as we saw in the previous example, we also need to look at the targets, day-to-day targets also. So there are newer recommendations to look at CGM targets where the time in range, which is 70 to 80, should be more than 70% in a 24-hour period. The time above range of more than 180 should be less than 25%, and time below range less than 70 should be less than 4%. So it really impacts the quality of life, and people would say that why do so much, it will not, that will cause a lot of diabetes distress. So this is a survey that was done for a lot of people who have type 1 diabetes, and this came out in 2013, that those who were checking their blood glucoses multiple times a day, and those who felt in control of their own care and had fewer glucose highs and lows, had actually felt that they were having a better quality of life versus those who were giving themselves fewer shots. So, having a better quality of life doesn't mean pricking lesser times. It actually helps to have the sensor in place and have a better control, because overall their feeling also improves. And of course, we have better technologies now so that we don't need to prick so many times, and even the insulin pumps that Dr. Ganesh will be talking about. Now, I would want to talk about insulin titration, because now we have understood the basics of insulin types and the need for the control. So let's look at some general principles. It is best to observe this blood glucose pattern over a period of 7 days, and ideally over a period of 2 to 3 weeks. It is very important that we get a blood glucose log which has information about carbohydrates and insulin dosing. and no adjustment should be based on a single high or a low unless there is unexplained severe hypoglycemia. And it's always best to fix the hypoglycemia before working on the hyperglycemia because that is of immediate threat. So, first, take your time, gather the information. It becomes very important that we are not in a hurry to fix the blood glucose, in a hurry to change the insulin doses. So, get the blood glucose log, look at the pre and the 2 to 3 hour post meal blood glucose levels, and then go through your checklist of various variables that are affecting the blood glucoses. So, what are those variables that we should look into before we actually titrate the insulin? So these are some precipitating factors that will lead to either high or a low blood sugar. So we do need to talk about these with the patient before we actually make any changes. So let's look at them. So did the child or the parent miss an insulin dose with the fear of low blood glucose? Say they're having 70, 80s blood glucose and they thought that, I would not want to give an insulin dose, so let me not skip the insulin. So of course there's going to be a high blood glucose once the child has eaten, and later on they may end up with a high blood sugar. Was there a change in the insulin doses recently? Have they started school and suddenly there is a lot of physical activity, or have they joined a new class like a tennis class where there's a lot of cardio that is going on that will affect the insulin sensitivity? Are they counting their carbohydrates correctly, or have they started to eat out more frequently? Are they missing any meals? Has there been a reduced appetite, or are they eating a lot of fatty meals that is going to cause a spike later on? Has there been an intercurrent illness that is affecting their blood glucoses and they're having high blood sugars, or any new medications that were added for this coexisting illness that is causing them to have high blood sugars? Or has there been a change in body mass index? Once the child gains a lot of weight, insulin resistance tends to develop, and that could also be one reason why their requirement goes up. Or if the child is in puberty, that also causes higher insulin resistance. Then are they giving the insulin properly? Are they giving the insulin actually in the same area causing lipohypertrophy? Or they traveled recently and they didn't store the insulin properly, and that's why it's not efficient enough and the requirements of doses have gone up. Or sometimes they adjust the insulin themselves and they're not discussed with the doctor or the diabetes educator, so that in itself can cause a low or a high blood sugar. And are they cleaning their hands properly before pricking, or are the strips expired? So these are some factors that need to be considered before we talk about insulin titration. So let's look at this example. This is a child who has type 1 diabetes again, and their fasting pre-lunch and pre-dinner blood glucoses are these. So overall, they're having a high fasting blood glucose. The pre-lunch is above 200s and pre-dinners is overall okay, but some 190s are also there. So I would give you a few seconds to think about what more information would you need with this. So like we said, we would want to actually look at the post-meal blood glucoses as well. So here are these. So post-meal glucoses, which is after 3 hours, are always high. Every time they're more than 250s or so. So is that enough information for us to actually say that, yes, we can make the changes? No, we do need to remember the checklist, and we would like to know the in-between snacking. So in between, did the child snack here that led to this high blood glucose? Or any extra insulin doses was given? So did they give the insulin dose and still the blood glucose was high over here? Was there any physical activity here and here, and that's why this blood glucose has come back down to normal? Or are they eating frequent carbohydrates, and how many carbohydrates are they eating, so that we know that actually they're not miscalculating their dose that is leading to a high blood glucose? So this is all the information you gathered here. So there are no carbohydrates or insulin that was given over here, and we see that overall there is nothing missing except for the fact that they're having some physical activity prior to the dinner, and that is what has caused this blood glucose to go to a little on the normal side. So our analysis, all three our post-meal blood glucoses were high. And what are the factors to consider? Any snacking with carbs was done? None. Was there a delayed administration of insulin? Because at times, for the fear of the child not eating properly, they may not be giving their insulin on time and they may be giving it late. Are they eating the meals slowly? Which, if some kids eat their meals over a period of 45 minutes, and that may actually cause the blood glucose to go high. Yes, I'll be done soon. Improper carbohydrate counting that is there. Was there a mismatch in the pre-meal insulin bolus? And that's what it looks like it. So we have to look at other factors before we correct and before we change the insulin dose. So now let's look at this one. All the blood glucose here are normal. All sugars are perfect here. Any changes that we would recommend? Let's look at this. So here, the post-dinner blood glucose is in the range of 150, 180, but the child is waking up with a 90 and 100. So there is a drop in the blood glucose by 50, 60 points by the time they're waking up. So this is a significant drop. We do need to consider, do we need to adjust the long-acting insulin if there is a drop in blood glucoses after the effect of the rapid acting insulin of the dinner is gone, and still there's a drop by the time they're waking up. There may be the insulin, long acting insulin may need to be adjusted at that time. So fixing hypoglycemia always takes priority because there's an immediate danger. There's a risk of seizure that can be there. And slowly the brain cells start to have apoptosis. There may be memory loss. Or if there's a severe unexpected low, then you may have to consider there may be hypoglycemia unawareness that is there. And that's why the child did not have any symptoms. So we do need to take that into consideration and fix the hypoglycemia first. When we're fixing the hypoglycemia, it's very important that we counsel the parent well in advance that there is going to be high blood glucose while we are fixing the hypoglycemia. So they need to be very patient and not keep adjusting the insulin themselves. Usually when we do change any doses, 10% is the way we make the changes, unless there is a pattern of severe lows, or if they're on high total daily dose requirements of more than 50 units per day, then we usually use a 20% criteria to make a dose change. So with that, I would end my talk by some takeaway points. It's very important to know the ideal insulin therapy and its basal bolus regime using long-acting analogs and rapid-acting analogs are the best way to take care of people who have type 1 diabetes. It gets very important that we match this insulin with carbohydrates and use insulin to carbohydrate ratio. And there is no fixed dose of insulin that should be used. And before we adjust any insulin, it's very important to consider all the other factors that would be causing a high blood sugar. And we should be teaming well with the endocrinologist and be the learned diabetes educator and give all the data, present all the data before we actually make adjustments and give the idea to the endocrinologist that this is what may need to be done. And that ends my talk. Thank you very much.